Allora, carissimi specializzandi in pediatria nella facoltà di medicina e psicologia, siamo qui riuniti perché ho il piacere di introdurre il primo di una serie di meeting magistralmente, come dire, organizzati dal collega Jacopo Pagani, che mi ha aiutato tantissimo nel realizzare questo momento formativo di elevata qualità. Jacopo Pagani, questa storia è partita perché Jacopo Pagani circa un anno fa mi propose di invitare come visiting professor il professor Vinay Nadkarni, che è qui con noi e che è un esperto internazionalmente riconosciuto in tema di formazione in emergenza in pediatria. E io appena Jacopo Pagani me lo propose, non solo per la maestria e la meticolosità che riconosco a Jacopo nell'organizzare questo tipo di iniziative, ma anche perché ero memore dei miei primordi di specialista in pediatria. Purtroppo parliamo di tanti anni fa, quando ebbi, come dire, l'avventura di avere i primi incarichi in posti sperduti, non come dire, in cattedra o come primario qui alla Sapienza o alla UOC del Sant'Andrea, dove posso avere qualunque tipo di consulente in qualunque tipo di situazione, ma un pediatra si può trovare a lavorare all'inizio in un posto di primo soccorso, come capitava a me, ed essere da solo con un'ambulanza e due infermieri, e quindi bisogna avere la possibilità di soccorrere e di offrire l'emergenza e l'assistenza necessaria anche in condizioni di emergenza in ogni situazione. Quindi se è vero che come direttore della scuola di specializzazione io mi occupo della formazione a 360 gradi e quindi ognuno di voi circola nella nostra rete formativa che si occupa a 360 gradi della vostra preparazione, il momento della formazione relativa all'emergenza in pediatria è un momento fondamentale, e quindi ci tenevo molto che si potesse realizzare quest'idea che mi ha proposto il nostro Jacopo Pagani, invitando il nostro esperto Vinay Nadkarni, che a questo punto inviterei a iniziare la nostra prima delle numerose giornate che abbiamo programmato e che è incentrata sulla gestione del team nella emergenza in pediatria. Quindi io passerei augurandovi insomma di fare tesoro di quello che ci dirà il nostro collega. Darei inizio a questo primo incontro. Prego. Grazie. Non parlo bene italiano. So,
They practice what to do when someone's injured and a new player comes on the field. They train for all this. And this is the type of team training that we should be able to accomplish. In fact, we know we're starting to learn from published studies, like this study, teamwork, communication, and resident leadership in the delivery room can be improved by a series of short sessions trained during the neonatal rotation. Just a very short 30 minutes once per week per resident can improve their performance in leadership in delivery room, not on simulations, on real babies. And we also know from this study from Children's Hospital of Atlanta, Karen Hebar, the details are not important, but for each portion of teamwork, communication, situational awareness, and closed-loop communication, a series of 3 simulations during the rotations of residents improve the scores and performance during simulation and during real patient care. So we can teach teamwork, we can teach communication, we can coach situational awareness and communication. It's possible, and it can work. In fact, one of our fellows studied resuscitations. He put a camcorder, he put a video audio recorder on the body cam of the providers when they went to codes. And he recorded what they did and what they said and what they heard. And he assembled them. And he discovered that the way people instructed people to work, start chest compressions, stop chest compressions, ventilate faster, ventilate slower, the words they used were different at every code. And there was a lot of confusion. So he created a consensus template of specific words so that when we trained, the word stop or stop on the count of 5, 5, 4, 3, 2, 1, stop. He could decrease the pauses. He could improve the quality of CPR delivered in simulations and in real codes. So the standardized communication during teamwork can improve the performance and the outcomes. This is a very important type of approach that can be applied to specific situations. But we know that the biggest problem during team resuscitation, teamwork in resuscitation, is communication. Errors, not in knowledge, not in skills, but in the communication. Why? Because the emotion and the bias that we have, not listening and not responding as a team, can decrease the efficiency of the team. And so we have to create a environment of psychological safety, the freedom to speak up, the freedom to debate, openly debate, when we have a respectful difference with the team leader. If we are just quiet or if we are shut down, the patient is not going to get the best care. So what are these challenges? We know that here we have level of evidence, we have patient factors, we have environment factors. We know that what we know has to be processed and taught, learned, remembered, that we have to act. We have to act well. And if we do so, we can measure the outcome in terms of whether an intervention works, whether it improves quality of life and outcome. But the key is really to act and act well. Oftentimes, in a team, we step back because we're afraid to make an error. We're afraid to make a mistake because If we do nothing, then we can't really make a mistake. But if we do something, we can be either doing the right thing or we can be criticized for doing the wrong thing. And so we have to figure out how to make it safe to act and act well, and to discuss how we change our actions to improve the outcome of the patients. In my, oh, this one didn't, doesn't animate. It's okay. So in my hospital, at the Children's Hospital of Philadelphia, we have 600 pediatric beds. We have 240 intensive care beds, 140 neonatal, 100 neonatal, 140 pediatric and cardiac intensive care beds. Our hospital is, like Bambina Gesù, is a tertiary quaternary care hospital, a lot of referrals. But when we measure how many people are taking care of the patients in that very rich environment, there are more than 1 million possible teams of 5 that could be called to respond to an emergency in our hospital at any given time. How are we going to train all of those people to be like the pit crew? It's not possible. So we have to think about how to have roles, how to play with people we've never met before or have not worked closely with before, but to efficiently resuscitate or treat an emergency in a child. So we have to use some training techniques that make us better team players as well as leaders. We have to know our roles and know how to switch roles in order to do a good job. So how much do we have to train? COVID is teaching us a lot about herd immunity. How many people have to be immunized in order to be safe to take off the mask? We're learning a lot, but we should apply this principle to training for techniques, for systems, for problems in the hospital. How many people need to be trained in basic life support? How many people in PALS? How many people in our different types of environments? Is it enough to have 1 person trained, 2 people trained, 5 people trained? How many people need to be trained around a patient to make it safe for the patient? Because many of the skills that I have or you have, if we're coached, if we're led in the right way, we can perform very well without necessarily being an expert in the specific problem that we're facing. Think about PALS. Think about airway patients. Think about cardiac patients. In fact, we have many different types of patients, and we try to put them into one card. We try to put them into one size fits all. And this may be good for taking teams from beginner to average. But if we want to get from average to excellent, then we have to do specific training, just like the football players. We can take a lot of children, we can put them in camps, they can become good from beginners. But only a few of them playing together all the time are going to become champions and championship teams. We know that the causes of arrest from infancy all the way up through adolescence and older people is different. It starts out with the first breath of life. We oftentimes can have congenital heart disease in the babies. We then have but as we get older, the respiratory distress, the respiratory failure, and then the cardiac arrhythmias become more apparent. Because of this, we can't have one size fits all. We have to think. We have to have a team that has guidelines, that has protocols, but then also where the team leader and the team members are thinking and adjusting. This process is called situational awareness. Situational awareness is understanding the state of the environment for perception, communication, and then projecting to the team what the team leader is thinking. Many of the second, third, and fourth year residents were just practicing how to summarize, how to project what they're thinking in their brains so that the whole team can understand the direction, the reason why they are making a decision in only a few words. Because if we go into a long description, we're sitting here and talking while the patient is deteriorating. But if we can communicate our thoughts and reasons in a very quick and succinct and standard manner, we can oftentimes make a big difference. The key is, if we're a patient and we're getting sicker, if we identify the problem and communicate it well, we can recover. But the further and further we get into the process without addressing the problem early, fluids for sepsis, antibiotics for sepsis, if we wait until it's late, the outcome is poor. So by working in this area before the steep drop-off, the team can make a big difference. But teamwork can't happen just by itself. This is an example of the individual getting trained just in time, just in place on the skills they need, the team rehearsing together, and then the environment. Because the individual, even a champion on a poor team, doesn't win the championship. So it's the skills of the individual, the teamwork, and then the environment, to make the environment support the team. So in our hospital, for CPR, for instance, we started to take a cart with a mannequin and a defibrillator, and instead of asking people to come to a course once every 2 years, we brought a simple training program to the bedside of the sickest patients, the patients that were most likely to arrest in our ICU. We brought the training materials right outside the door. And in 5 minutes, we had the nurse, the respiratory therapist, the resident, the fellow, the attending, practice CPR, back mask ventilation, whatever this patient was most likely to need in the next day or two. And this simple rolling refresher cart was like a booster shot. It was a little bit of training frequently, we call spaced learning, in order to improve the skills that I might need. Just like going on Google. When I want to find out how to translate a word, I go on Google Translate. I get that word right now. I don't go to a course a year ago and try to remember the definition of something. So it's just in time, just in place, and it's focused on what I'm worried about I might have to do for my patient, because now I'm going to remember it. And that type of training is very effective in improving outcome. For instance, these are the chest compression rates before training on the little mannequin right outside the door. And after 5 minutes, let's go back. After 5 minutes, this wide 40 to 150 became 90 to 120. So they learned very quickly the cadence for delivering chest compressions. We also demonstrated that when this type of rolling refresher training achieved better guideline compliance, we had more than 4 times improvement in survival of the patients, translating the training to patient care. We then added debriefings. After the events, we reviewed the events, what went well, what could be done better, what was the rhythm, did we need a shock, what could be done better? And when we did that, we showed that there was an improvement in each aspect of the quality of CPR delivered, but more importantly, we demonstrated in the dark bars that there was almost a 50% improvement in survival of the patients with good neurologic outcome, from 25% to 50%. So the training improved the process of care, improved the patient outcome. This was the first demonstration that the training affects outcome. This is what convinced our administrators to invest in just-in-time, just-in-place training, because we could see not only the process of care and the confidence and competence of the providers, we could also see the result in patient outcome. We did the same thing for central line infections. We had a problem with central line infections. We brought a rolling refresher card around to those who were about to have their dressings changed. They practiced on the mannequin. They had to go with the guidelines. They had to go with their protocol. Once they could do it 100% correct on the mannequin, they could walk in and they could do it on the patient. And we saw our central line infection rate come down. In fact, in the United States, central line infections are very expensive. The insurance companies will not pay for any of the hospitalization if there's a central line infection. So by doing that training, which cost money to go and do time and effort, we saved the hospital $4 million because they got payments for the patients because we were preventing these infections. This is not only true in big hospitals in the United States. Here's an example where the same approach for bag mask ventilation in the delivery room was provided to lay providers before the nurse midwives, before the technicians started their shift in the delivery room in Tanzania, Africa. They went to a mannequin and they practiced bag mask ventilation because that was the most likely resuscitative event that they were going to need to do. And they did it until they got a good score on the mannequin. And then they were allowed to start their shift. And in doing that, they improved the survival outcome of the newborn babies by 25%. They saved more than 1,000 babies with good neurologic outcome, with 5 breaths of life at birth. A very simple intervention, but a demonstration that just in time, just in place, spaced learning can make a difference. Now, what do we know about pediatric CPR? We know that high quality CPR is not common. We know that better CPR is associated with better outcomes. We know that point of care, or this just-in-time, just-in-place training, can improve CPR quality, and that when you add debriefing to that, you can improve survival outcomes. We also are learning that goal-directed, blood pressure-directed CPR is even better than depth-directed CPR, but we don't know if we can train people to use it. That's the missing link. And so we are building better monitors to simulate blood pressure so people can practice titrating. And we are identifying with our electronic medical records early warning scores to identify the highest risk patients and providers. And then what we're doing is we are identifying all of the steps where we can intervene with training, and we're adding debriefing right after the events and a week after the events, so that we can discuss and improve based on real patients, because that's when people listen. When you have a real patient who has a real event and you want to do better, then everybody comes and everybody appreciates it. When you have lectures like this, where you're just like talking, then it gets boring. You need a lot of coffee to stay awake. So we have to figure out how to bring the message to the bedside, and from the bedside, change the message. This is our emergency department at the University of Pennsylvania Hospital, the adult hospital next door. We also do this in our own room, but we videotape all of the resuscitations so that we can review them, we can learn from them. And we do simulations in the resuscitation bay to simulate the procedures that were just done the day before, the week before on a problem case. We can capture from the video feeds the monitor, the ultrasound image, the video laryngoscopy, and the movement around the bedside during the trauma resuscitation. We can generate a report card based on the quality, time-critical interventions, and the quality of CPR for CPR events. And here you can see in simulation in our emergency department, a simulation and then the report card that is generated. It's like instant replay in professional sports. In these days, can you imagine a football game, basketball game without instant replay? It's used for officiating in tennis, right? But where is it in our hospitals? We don't review. We can't look at it from 10 different angles in 10 different ways and have commentary from experts on how we're doing and why we're doing it. When we think about teamwork and what it means, to me, it's about resilience. It's to know what has happened, to learn the facts, and then to respond to those facts, to know what to do in relation to those facts. And then for situational awareness, to monitor, to be situationally aware, to know what to look for, what to anticipate. In fact, a few minutes ago, we were just practicing taking care of a simulated patient and anticipating forward what the next possible things would be needed for that patient, and preparing while we're taking care of the patient with the current therapy, what's the next therapy that might be needed. Anticipate. And then once we have gone through that cycle, start again to review the facts. Essentially, start again. When we think of a patient care event, we learn, respond, monitor, anticipate. But we can capture the details, and then we can replay. We can simulate that event and do exactly the same thing in debriefing, where we can learn from the real patient, and then we can disseminate that learning across all of the teams, not just the team that was there, but all of the residents, all of the nurses can benefit if we replay it until we have a good outcome. This is an example. In my hospital, we had a patient, a trauma patient. It's the USA, a gunshot wound into the chest here. Truthfully, the patient had an exit wound on the back of the shoulder here. But when the real patient came in, the patient was hypotensive, needed massive transfusion, and the trauma team did not log roll the patient and find the exit wound. It was a mistake. The patient survived, but it took a long time to resuscitate. So the next day, the next week, we brought the mannequin in, we recreated the situation, and we ran all of the trauma teams through the problem we had the day before over the next week, so that they could also learn and reinforce the importance of doing the complete exam and log rolling the patient. It wasn't punishment. It was not punitive at all. It was simply rehearsing and understanding the importance, because believe me, the whole hospital knew all about the fact that there was a delayed recognition of a gunshot wound exit. And so it was addressing the problem with the teams as a system problem, not as an individual problem. In our delivery rooms, we use eye tracking glasses that track where our eyes are moving, what are we looking at. And so in the delivery room, we can see the red hot spots, the face of the newborn baby, the chest of the newborn baby. This is where the expert newborn delivery doctors look. They look at the heart rate, they look at the face, they look at the chest. They look at the face, they look at the chest, they look at the heart rate. Maybe the pulse ox, the heart rate, the baby's chest and face. The new trainees, they look at the heart rate, the respiratory rate, the blood pressure, the saturation, the chest, the head, the heart rate, a very different pattern of what they use to guide their therapies. And so by understanding what they're looking at, where they're standing around the patient, we can start to improve the teamwork and the learning curve of the trainees. We can start to understand, what are they looking at? What does the expert look at? What does the new trainee look at? How can we get them more to match? Why is the attending looking at the heart rate and the face and the chest, and the face and the chest and the heart rate? Because they're using the clinical signs and not the numbers in order to manage the patient. And so we can learn a lot from that. Here in our emergency department, we're doing a simulation in the trauma bay. This is the team leader, the doctor. This is the charge nurse. You notice they are wearing near infrared headbands, near infrared spectroscopy headbands. It's measuring non-invasively the brain blood flow underneath the headband. so that we can see what part of their brain are they using. But in the simulation, we can dial up the stress, we can dial up the task load, and we can find out when they reach their limit and when they need to hand off a task. And they can start to learn how to self-recognize, ooh, I'm getting task overloaded. I need to hand off this task and that task to get back to my comfort zone. Some are better than others. Some can multitask, some can't. They can learn themselves about what their capabilities are and how they best perform as a team leader. Some manage a lot of things, some hand off a lot of things. There's not one right way. We're not all the same. What about where we stand? Every resuscitation we do at Children's Hospital of Philadelphia, we make a map after the code. Where was all the equipment? Where were the people standing? Who was in what place? So that we can understand how the human factors and the dynamics around that child either promoted or detracted from the resuscitation. About 75% of the time, we find that the way the room and the people were configured was good, was helping, was facilitating the appropriate way. If we always insisted and tracked on one single configuration, it would not be good for all patients. Because, as you know, they have different things at their bedside, the ventilator, this and that. And so it needs to be personalized, a general scheme, a general principle, and then adjusted to make it just right for the patient and the team. Betsy Hunt at Johns Hopkins has done a lot of work in this area about human factors, resuscitation, and a rapid cycle deliberate practice to improve outcomes using ergonomics and human factors. If you think about one of the beds in her room, she has a very scripted way in which the responders to a code blue in her hospital respond, where they stand and what they do. She's mapped it out very, very distinctly and very thoughtfully because she wants the chest compressor to be able to see the monitor and the CPR coach to be across from the chest compressor and the airway manager to be next to the person who's doing defibrillation, and then the resuscitation leader at the foot of the bed, organizing and in eye contact in a triangle with the airway, chest compressor, and the chest compression coach. So in her hospital, like my hospital, we have too many people. We have too many doctors, too many nurses, too many respiratory therapists. And so we have the luxury of programming these types of resuscitation team protocols in place. But what about areas where they're less resourced? What about when you don't have 6 or 8 people in an organized fashion? How can we make this efficient? The same principles really hold. It doesn't have to be one size fits all. Jacopo, I need some help. So in simulation, Adam Chang and Betsy did a nationwide study where they implemented CPR coach in this fashion across many, many, many centers. And what they demonstrated, they used no CPR coach versus a CPR coach in the same manner, 200 healthcare workers, 41 teams. And what they demonstrated in the dark bars was that for each aspect of CPR with a CPR coach in place, they were able to improve the compliance with the guidelines. And they were also able to demonstrate that they were able to decrease the number and amount of pauses, pre-shock, post-shock, and around the shocks. But how do we go from just training a team to training an environment? We're doing some projects in India and Africa where we're using WhatsApp and social media in order to learn and debrief after real events and after simulated events. With COVID and Zoom and all of the other techniques for remote support, we've been able to move forward with disseminating these types of projects across the world. We're doing work in India with resuscitation. And we're starting to address the key element, which is in this column, of teaching, learning, remembering, acting, and acting well. I'm just going to finish with a couple of examples to show you the types of things that we're doing in my hospital that may interest you. These are some examples of the rooms that we've created around the hospital. We don't have a big fancy sim center. We have rooms right next to the ICUs that are just in time, just in place, that the providers can come to and go back to their patients. So they don't even have to walk between a hospital and a medical school in order to simulate and have a skills lab. This is the one in our pediatric ICU. There's the one in the neonatal intensive care unit, in our operating room, in the first floor of our hospital. And so in each of the key locations, we have a room that's set up just like the room on the other side in order to be able to do this on a regular basis across the disciplines. Dr. Poe, help again. Thank you. These are some examples to show you that the teams are not the same. So you can see in different areas of the hospital, whether it's delivery room, whether it's in the parking lot, where a child was hit by a bike, a simulated child was hit by a bicycle while they were coming to the hospital. And so that's a two-person team. You can see in the operating room, it's a huge team. And so it's practicing in the same type of environment that you're going to be practicing that makes a big difference. One more time. Next slide. This is not just in the hospital. These are our clinic sites. So I think you here at Sant'Andrea, you have outposts, you have other arms. And so we take our simulator in a car, in a truck, and we go and we rehearse 4 scenarios: seizures, foreign body, airway obstruction, cardiac arrest, and an injury. And we take that to each of these little clinics and we present the problems and we identify the individual, the team, and the system issues, and also what they do well. Not just the problems, but actually what kind of teamwork they use to overcome challenges in their environment, so that they're feeling very prepared. Next slide. This was very necessary during COVID, as I'm sure it was here, where we had to change all of our processes very rapidly. People were very nervous. And so we had to rehearse a lot, and we used simulation to train the teams, both the teams who are going to be taking care of COVID and the teams who are going to be taking care of non-COVID patients, so that we could work out the details of how they moved, how they trained, and simulate how we would even transport the patients to get their CT or their MRI or whatever they needed. Here, it's hard to see, but here we are rehearsing ECMO and going into the elevator, which is a very tight space, a little bit less tight than here, but still a tight space for a big machine and a lot of people. And so you can see that we changed our procedures and our transport, and we figured out how to cut the time from cardiac arrest to putting them on ECMO from 57 minutes average to 35 minutes average. So almost half the time now to get a child onto ECMO through the use of team training and simulation. These can be very simple. This is a simple, this is the same mannequin you have here. It's just a low technology mannequin under a drape, but you see the fellows as they're beginning their training, learning how to put in central lines. And they're learning lessons about, 1, how to coach each other, 2, how to monitor a patient. The first time they do it, the same person putting in the line is instructed to also monitor the sedation for the patient. And the patient, the simulated patient, develops a pneumothorax. But it's very hard because they're putting the line in, they're monitoring that, they're overloaded with responsibilities. And they learn very quickly they need to hand off the responsibility for sedation separate from the person putting in the line. so that they can concentrate on that aspect and the other person can watch the patient. And so these simple kinds of simulations are team building. And they also teach the junior fellows that they can speak up to the senior fellows or the attendings, that when they see a problem that's important for the patient, it's important for them to speak up, not to be silent, because they may have very important information. If they don't speak up, the patient will suffer. Next slide. Sometimes the simulators are not plastic, they're human. This is, in our hospital, fortunately, we rarely have psychotic patients who are violent, adolescents mostly. So we don't have a lot of experience in calming them, in using medications, in restraining them so that either we don't get hurt or the patient doesn't get hurt. So this is a trained actor who's trained to act as a crazy person who's violent and rehearsing making the patient safe using the security and using the doctors and nurses in a manner that we can learn how to restrain a patient without becoming hurt ourselves or hurting the patient. So these types of events are also team training events where we learn to work together. But what's very interesting is after these types of training events, the interaction of security, the janitors, the clerks, and the doctors and the nurses is much improved because they see it's really a teamwork. They see it's really not that the doctors are in one area and the security is in another area, but they're working together to solve a problem for everybody. This is a very interesting simulation we did in a very, very difficult surgery. This is the interventional cardiologist. This is the ultrasound cardiologist. This is the OBGYN. And they're getting ready to deliver a child who has a very complex congenital heart disease. And so they were very worried about who would stand where, who would be in charge, how would they decide what were the problems they would encounter. This, in fact, is the day before the surgery, before the baby is born. They're just rehearsing. And that heart that you see up in the top right corner is actually an olive in a bowl of jelly being ultrasounded on a mannequin's stomach. And if we go back, you can see, can you go back one slide? Can you back up? Oh, back. Now, there we go. This is a simulation. This is the attending cardiologist, Jack Rome, one of the best cardiologists in the world. These guys are engaged. Can you see on their faces? They are intent. About an olive in a bowl of jelly. Come on. And so it's not the technology of the simulator. It's not how fancy it is. It can be very simple, but if the environment is very real, and because they knew this was a very difficult case the next morning, they were very engaged. They were interested. They were deciding how they were going to work around these difficult problems. So this can be done pretty easily. Now today we played with a blindfold. The team leader was leading cardiac arrest in a congenital heart disease patient with hypoplastic left arm, Glenn physiology, bradycardia, and then defibrillation, blindfolded here today. And that's what we do in our boot camp for all of the fellows that are starting in the USA. We bring them together for a weekend. We practice these kinds of cases, and they learn to run the codes blindfolded because the teamwork, the leadership, and the fellowship is improved by experiencing running a code blindfolded, because it forces the team members to be better team members, to work as a team. They have to, because the team leader can't see what's going on. They have to explain, they have to talk, they have to coordinate, and they have to decide together how to best take care of the patient. So this is great if you have all the resources. But now, today, we have resources that can be used virtually. We don't have to be there. We don't have to take a lot of time. We don't have to have a lot of technology. It can be done on Zoom, through the internet, pretty easily. We can pre-record. In fact, in India, we pre-record Indian children in shock so that the providers can see an Indian child, not an American child, and respond with the same cues that they have with the children that they're seeing every day in the clinic. How can we get this outside of the hospital? We also run these types of probes across the country. We take the van in these different states and we go to adult and pediatric emergency departments with these standard cases, and we create a performance summary for teamwork, for seizures, cardiac arrest, for sepsis, for foreign body airway obstruction, and we evaluate the emergency preparedness. Do they have the right training? Do they have the right policies? Do they have the right tools? Do they have the techniques? Have they practiced as a team? And we can identify how they're doing compared to other hospitals like them. This type of work, next slide, can be reported out. So you can compare your hospital, your emergency department to others that are similar to you. And then you can come up with a game plan for how to address those issues. And 3 months later and 6 months later, we can reevaluate. But the message really is that CPR, resuscitation, pediatric emergencies are a team sport. It's not what I know or what you know. It's what the team knows and can do. So I'm going to stop here, Jacopo. And maybe we can have some discussion about some of the issues, some of the things that come up in your environment. If there are people online that want to comment, or if they want to bring up an experience, but I want you to think for a minute about not just the problems you have in teamwork, but very importantly, the victories, the things that make your teams work well. When you say, so-and-so is a really good team leader, when they run the emergency response, things always seem to go well. I want you to think about the characteristics, what they do to make that happen.
I have a question regarding how the team can work well. You have shown about not just the specific role for everyone, but a specific place for everyone. And are there scientific evidence about this can work?
So, was everybody able to hear that? Yes. Yes. There's scientific evidence about the placement of the team members in trauma, that the process of care is improved with specific provider placement around the bedside in trauma. In pediatric cardiac arrest, from one center in real life and in about 20 centers in simulation, a specific training and CPR coach with designated places has improved process of care and in some cases outcome. My belief, my personal belief, is it's not the placement of the people. It's the concept and the training around that makes the team very good. So my personal opinion is that the delineation of roles and the training of those roles and procedures is more important than the specific places around. What do you think? You agree or you disagree?
Yes,
it's okay to disagree.
Yes, I agree, but I'm not an expert in emergency. So
I suspect you are.
it just community.
Good afternoon. I'm very happy to meet you. I'd like to bring up personal experience and then to ask you some questions about this. About 5 or 6 years ago, in our hospital, I was in the visiting room, and I made a blood sample to a baby who was 3 years old. And we were the resident, the nurse, the mother, the baby, and me. So after the blood sample, I told that this baby had moderate fever, and he wasn't feeding since 3 or 4 days, but it didn't seem so bad, didn't seem so septic. He had a good skin color, so we didn't, it was not so worrying baby for us. So I made a blood sample, and the mother went out the room and starting breastfeeding this baby. We went on with the visit in the emergency room, and we had a shout of the mother. We went out, and we saw this baby totally black, and it was not breathing. So I listened what happened, because it seemed like a joke, but it is not a joke. Because I took this baby, I went into the room, I placed on the bed. I felt the pulse. It was about 50 heart rate, no breathing. I started CPR. Then the baby, after 1 minute of CPR, the baby restarted breathing. So I wanted a font of oxygen just to help him. And I asked to the people who were with me. Now listen what they gave to me. The nurse gave me a tube with a valve mask, but the tube was not connected to the oxygen. So I was like this. The resident gave me the mask for aerosol to give the oxygen. So I thought I breathed like in the only that Jesus and Mary have to pray for the baby. And but this story happened really. Then arrived anesthetist team. But what I understood of this experience is that when there is an emergency, we go in panic, totally panic. The resident didn't remember the number of the anesthetist team. This nurse that normally is a very good one, is 50 years old, very skilled, but in that moment he gave me his tube and, without connecting to the oxygen. But in Italy we have this bad defect, because when we tried to make the briefing of what was happened, it remained just like a talk between friends, and didn't work, because everyone felt guilty, or felt judged, or felt we couldn't judge the action, the skill, because they thought that their person was judged and not their operate in that moment. So the briefing didn't work. We started fighting. Why you did this? Why? Look what you did. You didn't tell me the right thing. It was like a fight. It was not the briefing. But I think this depends on we are not used to do the briefing to anything. And when we do, we feel judged, we feel guilty. We don't want to be judged. This is my thought.
Wow. I think it's a very, not the specific example, but the feeling that you're expressing is very common all over the world. Nobody wants to be judged. Everybody feels guilty. And sometimes I think it's two separate debriefings. One debriefing is about how do people feel to, like friends, to talk about how awful it feels to have been with the baby a few minutes before and to assess the patient, and they were fine.
Yes.
They were fine. And then to walk away and then to have a cardiac arrest, a near cardiac arrest, it feels like you missed something. You should have done something different. You're guilty. And so to debrief about how bad it feels for everybody involved, that's one thing to take off the table first. Immediate, quick. Now let's talk about the specifics of the case, the medicine of the case. We kind of separate that. And in that, there are two ways of saying, why did you do that, right? One is, why did you do that? I wonder, why did you do that, right? This is like an accusation, like an argument. Another way is, you know, I was thinking this, and I'm curious. I wonder why you did. I wonder why you handed me the bag without connecting it to the oxygen. Her response might be, I didn't know if you wanted oxygen or helium oxygen. I don't, you know, there could be some reason behind her head.
That wasn't just nice.
No, but just there could be.
No, maybe.
No, but it's usually something you're not expecting.
His point of
You
view.
know, I thought you wanted to attach it yourself, so you knew it was firmly attached. So I gave it to you unattached, so you could attach it and make sure it was there. And you thought I made a mistake and didn't attach it by accident. Let's talk about that. So you can see where the frame of mind of the team aide is different from the team leader or the person asking. And so when we take the emotion out and we make it psychologically safe, we can start to be curious. We can say, I wonder why you handed me that. I wonder why you gave me an aerosol. Oh, I knew you wanted oxygen, but I thought you might need an aerosol, so I gave you both, right? Who knows? But when you start discussing it with curiosity, because you want to understand. Another trick. Don't start with the problem. Start with something good. Wow, 5 people gave me oxygen. That was great. Where did you guys find it? I didn't know we had 5 types of oxygen in our emergency department. Where did you find that? Oh, I got it from the cabinet. I got it from the coast guard. I got it from this. All of a sudden, you're talking about how great they were in getting you oxygen really fast.
You know how frustrated I felt, because to me it was like to be in a shop and not in a hospital, because I had the oxygen in 1 meter, but I couldn't have it, so I was crying. Because I was making CPR and I couldn't go.
So maybe the answer was, wow, you did such a great job of providing early effective chest compressions for a child who needed it. I'm so glad you didn't leave the baby.
Thank you to Jacopo and you, because I learned from you that's important.
But do you see how if we started focusing on the oxygen was there and I couldn't go get it, I'm so frustrated, I wish somebody had handed it to me, it's going to be a bad debrief. It's going to be difficult. But if you start with what a great job, what do we do? Early, effective, uninterrupted chest compressions are the most important thing for every child who has a cardiac arrest. Great job. Now, what could be done better? Well, it would have been better if we had oxygen in addition to the bag mask. How could we do that better? Next time, we do this, we do that.
No, the first thing, in the room, there was not the bag mask. In the emergency, you remember this case?
Yes.
There was not in the room the bag mask.
Yeah.
This was we discussed a lot about it with the nurse responsible
Yes.
for the.
Yes. So
Um,
now has that changed?
Yes,
I'm asking
after
you-
that case, there is always the back mask. This we with the nurses it worked, but it didn't work between the doctors.
So it's those are the types of things that we focus on in the debriefings to move it away from the individual performance. Now, your next question might be, most people then say, well, what if somebody just made a mistake? What if somebody did something wrong, bad? Yes, that has to be addressed. That has to be addressed, but it doesn't necessarily have to be addressed publicly.
Not public.
It can be
with
addressed.
the team.
Yeah, it can be acknowledged. Yes, there were some issues. The team can be reassured that we've discussed these important issues with the person who is involved, and that will be taken care of. But let's talk about X, Y, and Z. So we can move those very difficult emotional errors. We don't ignore them. We don't say they didn't happen. We acknowledge them, but we don't have to discuss them in front of everybody. We
No,
can
but
discuss-
even if we were only us, the problem I think is of the personal feelings and what you define the comfort zone. If we go out from our comfort zone, we are for first. We are not able to discuss our acting because it seems to discuss our person, and this is wrong. I think.
Yes. I think it also helps sometimes if a very powerful person or a very senior person expresses how difficult it was for them, how they wish they had done something different. Also, if a person can acknowledge their problem in front of the group. I wish I had recognized that as ventricular fibrillation 2 minutes earlier, because I know that I was biased and I kept on seeing a number for the heart rate and I kept on thinking the patient had a heart rate. Now that I think back on it, I wish I had shot 2 minutes earlier. Those kinds of things from a senior person empower the rest of the group to speak up and say, oh, but I could have told you, I could have done this.
Okay, I don't know if the folks have other questions, but today I am the director with the director of the live webinar. So, but I have a question for you, because in our country we have most pediatricians on the urban area, not in emergency, only in emergency.
Yes, primary care.
And they are away from the emergency room and from emergency in general. How many is important the simulation in this setting?
I think so. I think the simulation is very important in the context of primary care.
Your example, when you showed us your car or your
Yes.
van going to, so that was a very good idea, I think, because I'm here talking as a primary care.
Yes.
And so,
But to rehearse something you may, like a seizure
yeah,
or hypoglycemia, fainting, something that could happen that people are uncomfortable with in the clinic, right? To the point of stabilizing the patient and sending them.
transfer, yes, because we are the first
Yes.
ring of this chain.
And how do you manage all the other patients in the waiting room? How do you manage keeping the clinic going while this emergency is happening?
So
These are things that have to be practiced.
now we understand that this kind of education, of continuous education, is mandatory for us, because in the past we didn't belong to emergency.
Yes.
But now we are aware that
Yes.
this must be, and that idea was the future, a very,
Yeah.
very brilliant idea, because you
Yeah.
told us just in place and just in, and so we have to learn there, because we always go to training courses, but the hospital, but we must rethink, I think, about
Yes.
our primary care settings and how to be organized there. Because that's the future. You show us the future.
And the other thing that can be done is that the local ambulance service can be included. So they learn how to find the clinic, what's the entry, they meet the people in the clinic. So if an emergency occurs, they've done it before. They know how to negotiate the clinic.
So
how
it
to
must be so local also.
Yes. Think locally, act globally.
Yes, that's the good thing.
I think that in light of what we just said, it could be a good idea to start formation in communication, first of all, and working team, and with things already at the medicine school,
Yes.
so that at the moment of the residency, we already have all the bases to manage an emergency.
I think the importance of the training in the medical school is to get used to simulation. Skill training, very basic.
Very basic.
And then to build to teamwork, to a comfort with simulation as a way of training. Because there's a very important study from the National League of Nursing schools. They compared simulation starting in nursing schools with no simulation and just skill training. No advanced simulation, debriefing, etc., but just skill training versus skill training and debriefing participation. And what they found was that when the nurses graduated from nursing school and went to the clinical environment, they took less time to be oriented, less time to become competent, and they integrated into the team much better because they were used to debriefing, to thinking, to discussing, and they showed that there was an improvement when the training started early. It was not the content. Content of the two groups was the same. It was the methodology and the involvement in learning. The benefit of I think the benefit of the simulation and debriefing. Debriefing is the most important part of simulation. I think the benefit is the approach that the learning is universal. It's not the lecturer to the student, and that the why, that each of the person is expressing why they're thinking something, rather than just learning the protocol, the procedure. It's a little bit slower. It's a little more frustrating because it's easier just to say, do it right, do it by the protocol. But it's a short-term learning. It doesn't persist. It doesn't stay with you.
It's frustrating that at the first years of residency, I have maybe the contents to manage something, but I am unable to communicate with my team because of the lack of instruments to do so. What we just said, in fact.
You're like the cardiac surgeon
Yeah,
who
of
was
course.
from Cleveland
Of
Clinic.
course.
He said
You
he had all the
were
skills, he had all the knowledge, but
Yeah.
he just had to learn how to apply it by hard work.
And in a medicine school, the gap is bigger than in nurses school, because I had the impression nurses made a lot more practice till the beginning, while we spent 6 years only studying and acquiring contents, and then we are unable to practice that.
And I think the other nice thing about simulation and debriefing is it allows you to feel more comfortable making mistakes. I'm going to try. I'm not going to hurt. It's a mannequin. It's a plastic. I can't hurt it. So it allows you to try things that you wouldn't try before. And that's an important aspect to push the envelope.
Just to our colleague from primary care, if you want, we cannot have binary every month in Italy, but we can organize with Jacopo from now on every 3 months a refresh training, if you want, with all pediatricians from primary care.
Yes, I think some will be.
Coming here or going there?
Yeah,
Coming here.
So in our instance, we do both. We offer like a periodic training at CHOP at the hospital, but we also offer some things because a lot of the nurses, a lot of the technicians, they can't come that far. So we have to bring, or we train here, and then the leader, a nurse and a doctor, they go back and they run their own scenario there. It's tough.
It can be difficult to reach every primary
Yes,
care.
of course.
But oftentimes the most important ones to reach are the scouts.
The sort of model, we could think of a model of primary care settings. We are lucky if we have a nurse, because not each of us has a nurse. So we very often work on our own, also not only in Rome, but also in the small towns around Rome. And so I think we really need to be continuously trained and not only theoretically trained. So I think also for the residents, a different setting, because I don't know where they are going to work, whether the hospital or the primary care. It's very different what you would want. So also for them, it would be useful, I think, to have this different.
You think about
They could begin there working on their own, and so it's important if there is a seizure in the hospital or a seizure in a primary care setting.
It's completely different.
Jacopo will take care of that.
Yes. It takes more than Jacopo. It has to be champion. You have to identify some champions.
Yes, champions.
Yeah, champions in the general care area who want to do this, and then train the trainer and then disseminate, because it will kill one person.
So I have another question for you, because all is very nice, it's beautiful.
Yes, it's
What you
terrific.
say is beautiful.
Perfectly. Also that.
It's amazing,
works.
isn't it?
What happens when we apply everything we have learned here now today to a system with low resources? For example, tomorrow morning, the students have all is okay, it's beautiful, a lot of people during an emergency, but tomorrow morning, when we go to our emergency room,
We can.
we cry because I am me, probably a resident, and probably a nurse. We are 2 or 3 people in an emergency, not 6 people or 7 people like in your slide. So what happens when we are in a low resource system? How we can apply what we learned
So
today?
I think the slides are nice as an example. But the message is, it's more important for you to assess and train how to get the key principles done. Continuous chest compressions, good ventilation, vascular access, appropriate medications in your environment. This is what we do in India and Africa also, because they don't have half of the things that we have. Quarter of the things.
You showed that save life, save money.
Yes, yes. But it saved money in
We
our
should
system.
convince our.
Yes, but it saved money in our system because we're an insurance-based,
Yes.
private insurance system. There will be similar drivers for your administration, because if children have less central line infections, less IV infiltrates, etc., they'll go home quicker, they'll use less hospital research. I mean, there will be this balance, but you have to know what the metrics are for what they value. And that's where the needs assessment to identify where to focus the first efforts are, to make a difference in something that they feel is return on investment. Because then the funding, like I said, until we demonstrated the reduction in central lines, they would, you can do as much education as you want, great job, but they didn't support it. Now they support it. Now we have a lot of support for those programs.
We have to convince politicians to think not in tomorrow, but on a longer time.
On a longer term, it's difficult.
It's difficult.
It's very difficult. But there's something that they want to prove, they want to show. And if you can be the solution, then
We have to measure. And
you have to measure.
Yes.
And pick
to bring
something you're already measuring
Yeah.
to change. So you don't have to have a new system, you just add this on and change and see the result.
Sono tutte domande, ragazzi?
You have a question?
I have a question for them. When there's a team lead, when there's a good team leader, what is the quality? What is it that makes them good? Who is the best team leader here? Who do you think? I don't know.
The nurse.
The nurse. Okay, what makes them the best leader? What is the quality that makes them the good team leader?
Also because we don't work together a lot of times, so it's difficult to say who is the best
Don't worry about who.
leader.
Just think of
What?
think of an experience where you had some emergency, some treatment that
Very
needed
calm.
leadership.
The calm,
Calm.
yeah, because someone is
The experience.
assessed or updated that don't help in the situation of emergency, no? So I think that the team leader have to maintain the calm in the situation, the order
The experience
Experience.
in leading.
How do you know? No, you just know.
No, I guess so, because what I learned today is that the most important characteristic is to be able to lead the team, and it's something that you can't learn in 2 days. It's something that you have to acquire in many years. That's why I think that the experience is needed to do that.
Experience. What else? Does it have to be the smartest person in the room? Sometimes the smartest person gets very distracted. They know all these theoretical things, but they have difficulty making a decision and
the reality.
leading the team. Yes. So it doesn't necessarily have to be the smartest person.
Also the capacity to listen, no? Also the
Or to know the people they are working with.
Trust.
trust, yeah. Listen, and you don't believe the best, but you have to listen all the possibilities, no? Like we did today. So all the
To be confident with the environment also.
Yes.
Maybe to the skill to lead the roles of the people, because a lot of times you are in an emergency, you don't know the people that are working with you, but the good team leader has to know the roles and how to direct the orchestra. This you have, you do this.
I'm
you
always struck by what you're saying, that oftentimes the best leaders are perceived as those who hand off the tasks that can be handed off and only keep the ones that they must do. Whereas I think a lot of us feel like if we're the team leader, we have to do everything. And that doesn't make for a good team leader, because they don't trust the people. They get overwhelmed because they're trying to do everything by themselves. Sometimes we have to do that because of the circumstances, but oftentimes the best leaders are those that appropriately hand off the tasks that can be handed off, so they can concentrate on what they have to do. Very interesting. Yes.
I was thinking about the opposite situation from the opposite situation of Jacopo said. So in an hospital like yours, in Children's Hospital, where everyone is trained, in which way do you choose who is the team leader?
Good question. Because we have a big problem that sometimes if the emergency bell goes off, we have like everybody coming wanting to help, but it's like you can't tell. So everybody has to leave the room and you only invite back in. We have in our paging system on our phones, we have a team. So for different areas of the hospital, different of the residents are assigned to be the first responder and in the room. We also have some videotape so that for education, the residents can watch from other places. So they don't have to be in the room to experience what's going on, what are people saying, I want to learn from doing, and they rotate around. But it's a difficult problem because everybody wants to help. And oftentimes our problem is too many people and you don't know who's in the room and you don't have the right people in the right spots.
C'è un'altra domanda? Bene. Allora, noi ringraziamo Vinay per essere stato qui ed aver iniziato questo ciclo di meeting dedicati alla formazione. E il prossimo quando ci sarà, Jacopo?
Allora ragazzi,
Quindi invitiamo tutti, sia in aula sia in collegamento, ad essere con noi la prossima settimana. It was a pleasure. Thank you.
Thank you.